Good morning, everyone. My name is Trin Mai. I am the Senior Authorising Officer of the Restrictive Practices Authorisation Scheme in South Australia. Thank you for joining us this morning as we work together to strike the balance of effective prescribing and deprescribing. Today's forum is a shared initiative of state and territory authorisers who are working together with the NDIS Commission to reduce and eliminate restrictive practices and reduce the overuse of psychotropic medications. We have over almost 1,000 people registered to attend this event nationwide. This is without doubt our largest and most diverse audience to date, and it really signals the huge amount of interest and the demand for this content. I want to thank my state and territory colleagues for their support and collaboration and leadership on this very important issue. It is such a privilege to be working with people of immense talent and knowledge and generosity and commitment. We are coming to you today from the traditional lands of the Kaurna people on the banks of the Karawira Parry, which is the River Red Gum River on the Adelaide Plains. The Kaurna people of South Australia have been promoting good health and well-being and healing for 65,000 years. The red gum that the river was named for is actually known for its essential oils, which has been used by the Kaurna people to relieve coughs and colds and flus and sore throat and respiratory infections for a millennia. The sap of the river red gum is very high in its tannin content, and it was used to seal burns and cuts, and the heartwood of the river red gum was boiled to treat diarrhoea for children. The Kaurna word Ngangkari means healer, and the Ngangkari used 4 main healing practices: healing touch, visual cleansing, bush medicines, and spirit realignment. The people in this room today and the people from First Nations land across Australia joining us today know that and have learnt from First Nations healers that being well within ourselves is not just about the right medication at the right time, but it's also about being connected to our families, our communities, and our environments. The Restrictive Practices Unit and state and territory authorisers play a key role in regulating the use of medications to influence behaviour by NDIS participants. But this work doesn't exist in isolation, because the NDIS participant may also be somebody with complex mental health issues. They may be a child experiencing developmental traumas. They may be over 65 and receiving aged care services. The challenges that the disability sector faces may be shared by the health professionals in this room, the aged care staff, the paediatric staff, and professionals all across Australia. We face many challenges in this work, but we face them together, informed by our commitment to evidence-based best practice and our commitment to promoting people's right to good health and well-being. We are supported in this goal by some of the best hearts and minds nationally and internationally. Our keynote speakers today are Dr. Mark Horowitz and Professor Julian Troller. Mark Horowitz comes to us after a very long flight from London, where he's been advising the UK National Health Service on effective deprescribing. Professor Julian Troller is here from the National Centre of Excellence in Intellectual Disability Health from the University of New South Wales. We will break for morning tea at 10:45, where you will get a chance to network with your colleagues. We will then split into concurrent sessions where we will be joined by Connie Wu, who is here with the support of the Office of the Victorian Senior Practitioner, and South Australia's very own Dr. Barman Zarabi and the allied health team from the South Australian Intellectual Disability Health Service, bringing a multidisciplinary lens to this complex work. You'll be able to ask further questions of Mark and Julian in their Q&A sessions as well. Don't worry if you miss out on a session. They are all being recorded and will be available on our webpage afterwards. For the people in the room, if you would like to join the Wi-Fi under restrictive practices, the password is Adelaide25. To start us off, I'd like to invite Tamia Allen, the South Australian Mental Health Commissioner, to open this forum. Tammy has been the Chief Executive of the New Zealand's leading lived experience organisation and has served on the Mental Health and Wellbeing Commission in New Zealand. She has held prominent roles, including Deputy Chair of New Zealand's Suicide Mortality Review Committee, and has been the advisor to the Royal Inquiry into Abuse in State Care. Tammy has been a global advocate for suicide prevention and lived experience leadership for more than 2 decades. Please welcome Tammy Allen.
Nagdalu Tampali Nagdalu Gani Yatanga Imparenti. I want to also acknowledge that we're meeting here on Kaurna land and acknowledge the traditional custodians who have passed on their wisdom for 60,000 years. And if we can't learn from that wisdom when we're thinking about deprescribing, what can we learn from? I recognise their deep connection to the land, to the water, and to the community. I also want to acknowledge the lived experience that's in this room and beyond. Those who have taken antidepressants and psychotropic medications, those who still are, those who have struggled with their effects, and those who have tried to withdraw even without the support that they desperately needed. This discussion today isn't just academic, it's deeply personal for a lot of us. So are we willing to learn? Are we willing to put aside everything that we've known so far to learn something new today? I know that by turning up today, you've already made that commitment. So this journey is also very, very personal for me. I have lived experience of discontinuation syndrome, something I didn't even know how to word when I was going through it. I withdrew over 3 years, it took me to withdraw from 10 different psychotropic medications, polypharmacy, over 20 years ago. That journey was one of the hardest that I've ever gone through in my life. And that's why I'm so passionate about the conversation we're going to have today. You see, there's a problem that we all face. Too often, I'll hear people being told, you'll be on this medication for the rest of your life. This is the only option available, or this is the last option available. If this medication doesn't work, you're going to need another higher dose or another medication. And this lack of hope for people is absolutely devastating. It reinforces the idea that distress is purely chemical imbalance. That people are somehow broken if the first medication that they try doesn't work, and that polypharmacy, layering medication upon medication is the only path forward. Yet research, and you'll hear from Mark today about some of that, doesn't support that approach. The actual effectiveness of antidepressants is at best modest, with response rates barely above placebo in many of the trials. While they can help some, they're not a cure-all. Nobody I've ever spoken to, either lived experience or clinician, describes medication as the one and only thing that healed them. I'm not saying, note this, I'm not saying that they aren't helpful for many. For some people, it creates the relief and the space for deep healing, but they're never the answer on their own. Instead, what I hear time and time again is that as people move further into recovery, medication becomes a smaller and smaller piece of the jigsaw puzzle. So what matters more for them? Learning how the brain and the body work, understanding your thoughts, your traumas, and your emotional responses, and learning other ways. Addressing this physiological as well as psychological factors like inflammation, gut health, nutritional deficiencies, and having the time, space, and psychological supports that we need to heal. Yet in many cases in our system, we don't offer this. Instead of taking time to understand the individual, their environment, their history, their physiology, their lifestyle, we often default to medication as a first, a fast, and often the only response. What's more, making it our first response installs a sense of false hope that there's somehow a magic pill that's going to make it all go away. And we all know that it takes dedicated work and deep self-understanding to make it go away. at least a little bit. First, do no harm. I'm sure you've come across that phrase in your practice, the Hippocratic Oath. It tells us first, do no harm. And yet we know antidepressants and psychotropic medications have the potential to do great harm. That harm is sometimes immediate. You've seen sedation, emotional blunting, weight gain, metabolic issues, and other times it emerges much later as people try to withdraw and find themselves facing symptoms far worse than the original distress that led them to the medications in the first place. Now, it's not that I'm not excited about medications. I am excited by new research. I'm excited by emerging research into ways that we can mitigate some of this harm. I'm excited about the use of GLP-1 receptor agonists to help counteract antipsychotic-induced weight gain. I'm excited about the promising connection between anti-inflammatory treatments for depression. Those things excite me because this shows that we can be proactive using science to improve the outcomes that we see. But I'm also really deeply concerned by the lack of training in de-prescribing. Most prescribers are not taught how to taper medication safely. They're not taught, or many do not know how to cross-taper between medications into something safer. Few have been able to offer or know what the alternatives are beyond prescribing. And it's really lovely to see that there's some representatives in the room that offer some of those alternatives. If we don't know these things ourselves as professionals in this space, how are consumers who put their lives and their trust in us meant to know? And so people are left with escalating dosages, multiple medications, very few options for coming off safely because we don't want to wear the risk. At 26, my son was born very prematurely due to an antidepressant that I was on that I was told at the time was safe in pregnancy. We now know that it's not. At 30, I was on 10 different psychotropic medications, all for my mental health, and none of them were necessarily making me better. So another one, a polypharmacy cocktail was added. It was a nightmare. I wasn't really living. I was just simply existing. The colours, the taste, I'm sure Mark will explain this a little bit later, everything was just muted. I called it my whatever pills because life had become grey. I wasn't distressed, but nor did I really experience joy. And paradoxically, I became more suicidal, which is the reasons I went on it in the first place. And that was blamed on my depression other than being recognised as a side effect of the medications themselves, which we know now is very real. When I told my psychiatrist that I wanted to come off these medications, he discharged me. He didn't want the risk. I was left on my own. But luckily I wasn't entirely alone, unlike many people going on this journey. My husband supported me, even when others in my family were fearful. I found a really kindly GP that was willing to take on that clinical risk when others wouldn't. And critically, if there's pharmacists in the room, you are my heroes. Because I found an amazing pharmacist who didn't have to wear the clinical risk of me coming off my medications. But he researched for me the role of amino acids and micronutrients in managing my withdrawal symptoms, and those helped. They helped a lot. But they didn't stop the brain zaps. They didn't stop the electrocution-like shocks that ran up and down my spine and into my skull, which lasted for years after stopping my final medications at the lowest dose. When I tapered off the medications, I may not have had the support that I needed from my prescriber, but I did have one advantage in that I was already working in mental health, and I was working in an organisation entirely led by lived experience. Without this peer support, I wouldn't be in the position that I am today as Mental Health Commissioner. Since then, I have run and I've financially supported and I've been part of peer groups that talk about tapering in real life and online, where people share what works for them. In the early days, this was new, so some people tried to shut us down. They assumed that we were giving medical advice. Yet it was only when we collaborated with the Royal College of Psychiatrists to co-produce a tapering information booklet that our knowledge was trusted. Mark will no doubt share with us today how essential these peer support groups are for people's recovery. I also have a great admiration for the persistence of Dr. Miriam Larson-Barr, who, while working for me, focused her PhD on service user strategies for well-being during and after withdrawal from antipsychotic medications. This type of user-led research is essential for us to learn. And today we have more champions with clinical workforce who bring both the scientific expertise and lived experience to the table. Dr. Mark Horowitz, his research on hyperbolic tapering has transformed our understanding of safe withdrawal. And I wish you were around when I was withdrawing, Mark. Professor Julian Troll, I don't think he's here. Oh, yeah, welcome. You advocate for better prescribing, better deprescribing, better systems. And my friend, Dr. Miriam Larson-Barr, who's contributed invaluable research on the realities of withdrawal. So looking ahead, what needs to change? Here's what I think. It's only my opinion, but I hope it's shared. Medication should be part of a suite of options, all of the menu, not just one option. Prescribers must be trained in deprescribing, not just prescribing. And we must fund and implement safe tapering protocols as standard care. We need better long-term follow-up and support for people coming off medications. So today's discussion is about striking the balance. And I challenge us all that when we walk away today, we consider what we can do to influence safer medication management and what we can do to influence the support of broader complementary therapies in this space. Most of all, let's leave today's discussion ensuring prescribing is done well, deprescribing is done safely, and most importantly, that we do no harm. Thank you.
Thank you so much for that wonderful opening remarks, Tammy. You very much set the tone for the collaboration, the innovation and the intersectionality of experiences that will very much be informing our conversations today. Our first keynote speaker today is Dr. Mark Horowitz. Mark is a clinical research fellow in psychiatry with the National Health Service in the UK and a visiting lecturer in pharmacology at King's College in London. He has a PhD in the neurobiology of depression and antidepressant action and is an expert in psychotropic medication withdrawal. His work includes contributions to the Honorary Clinical Research Fellow at the University College London, and he is an Associate Editor of Therapeutic Advances in Pharmacology. He is the leading author of the Maudsley Deprescribing Guidelines, which has been approved as a clinical research by the Royal Australian College of GPs. When Mark presented for us at our November webinar, we were flooded with requests for a follow-up. People contacted us saying, I need my team to hear this. I need my doctor to hear this. I need my families to hear this. So we're so thrilled that he agreed to do a follow-up session in person for us all today. Mark has been a one-man revolution. I think he feels like it's a one-man revolution at times. But looking out across this room, Mark, you can see the swell of interest and commitment and passion for safe deprescribing. I welcome to the stage Mark Horowitz.
Thanks very much for that kind introduction. Thanks for inviting me to talk. I'm going to crack on here. So I want to talk about how to safely stop psychiatric drugs. I'm going to be talking a lot about antidepressants and antipsychotics, but a lot of what I'm saying applies to all classes of psychotropic drugs, including mood stabilizers, benzodiazepines and gabapentinoids. And to sum up, what I'm going to talk about is, many psychiatric drugs can suppress symptoms and can be helpful for behavioural control in the short term, but in the long term can cause more harm than good. All psychiatric drug classes cause withdrawal symptoms when reduced or stopped. And withdrawal effects can include mood and behavioural symptoms that can mimic or look like a return of an underlying mental health condition or disordered behaviour. and often leads to misdiagnosis, that the person needs the drug rather than the idea that they should be stopped more slowly. And stopping them more slowly, which means often taking months and sometimes more than a year in people that are on these drugs long term, and especially going slowly for the last few milligrams, can reduce withdrawal effects and make it easier for people to come off these drugs. A good rule of thumb, if you remember, no other words from this lecture, is that reducing the dose by about 5 or 10% of your most recent dose every month for a long-term user is a tolerable rate for many patients. That means that as you get to lower doses, you need to go more slowly. Some people find that surprisingly slow, but that's what it often takes in practice. And this is a barrier to implementation, that this often requires using forms of the drug other than tablets and capsules available from pharmacies, using either compounded medications or liquid versions of drugs, which presents difficulties in practice. And I'll talk about how to manage. I'm going to play a patient montage put together by people that have used mostly antidepressants and their experience coming off it, to give a bit of a flavour about what the process feels like.
Why were you first prescribed an antidepressant?
I was prescribed when I was 22, and I had just had a relationship breakup.
I was prescribed an antidepressant in 2013 for a chronic pain condition called trigeminal neuralgia.
I was first prescribed an antidepressant because I was going through some dark times in life. I had an ACL reconstruction on my left knee, and I was going through school at that time.
How did the antidepressant make you feel?
I felt like I was just like a robot. I was very emotionally numb.
I still had the anxiety, but it was numbed down. But unfortunately, not only did it numb down my anxiety, it numbed down my emotions. You know, I couldn't feel any intense happiness or sadness anymore. I lost the ability to cry.
I put on a lot of weight. I completely lost my libido, and I just found myself incredibly tired.
When I was first put on these drugs, I thought it was fantastic because it quieted my mind and numbed me, but I didn't know that the trap I was digging for myself.
What has your experience been when you came off or reduced the dose of the antidepressant?
My brain felt like it was burning and splitting, but everywhere, along with pains and mushing feelings I can't describe. I was forcing myself to eat. I lost around 14 kilos. My clothes became really baggy. I had diarrhea I couldn't stop. I was super sensitive to light and sound, even hot and cold.
All hell broke loose. I have never experienced the terror, the extreme physical and mental upheaval that I went through.
I experienced my first major depressive episode like nothing I'd ever experienced before in my life, but I just thought it was me. It was much worse than any low mood I had previously felt during my first 27 years and before being prescribed an antidepressant.
I became sensitive to noise. I was fearful of people visiting. I couldn't watch the television. I couldn't read a book.
And I experienced akathisia for the first time ever, which is actually quite difficult to even describe, but it feels like an extreme panic attack combined with just explosive feelings of pressure in your brain and your entire body.
I had intense anxiety, intrusive, dark, looping thoughts. I developed akathisia and paced around the house so uncomfortable in my own body. I wanted to rip my skin off.
Dizziness and also these sort of zappy electric kind of sensations that I've heard called brain zaps. They didn't worry me so much as the emotional, psychological tsunami that then hit me.
Inability to function, struggling to walk in a straight line. I could go on and on. Yeah, just struggling to stay alive.
How has antidepressant withdrawal impacted your life as a whole?
It has pretty much destroyed my life. It's traumatized myself and my family and caused extreme distress.
And one of really the worst thing that's been for us is the isolation in regard to medical professionals. They just do not understand the severity of withdrawal symptoms. It was just terrible visiting doctors and realising they had absolutely no idea about this experience.
Friendships have been affected. People just can't comprehend how a prescribed medication can cause so much harm. I've lost years of employment as a direct result of antidepressant withdrawal.
It's hard to think of an area of life that it hasn't impacted. Obviously had a massive impact on my family, massive impact on my sense of well-being. I mean, it's an experience that I just wouldn't wish on anybody.
Taken everything from me, taken my job, my ability to work, took my partner off me. It's taken everything from me.
What did you need from health services that you did not receive?
I needed health services to know about this. I needed them to know what I tried telling them was real, so they could help me, or at least be understanding and not dismiss me.
I needed to be treated with more empathy and compassion. I was often treated as a non-compliant, difficult patient who couldn't accept the reality of her condition.
That last doctor, when I tried to talk to him about what was going on, would have been able to see through my tears and been able to differentiate the symptoms of withdrawal from relapse.
I really needed acknowledgement and validation that what I was experiencing was real. I also needed a safe place to go where I had no fear of being sectioned or drugged up to manage my symptoms.
They denied the possibility of withdrawal with such conviction that I left every appointment feeling like a crazy person. And their lack of understanding made me feel like I was the problem.
Give some context to some of what we've heard there. If I can go to the next slide. I do that. So what are some reasons why you might want to stop antidepressants and other medications? There's lots of reasons why medication may no longer be needed. Thinking in the context of restricted practice, challenging behaviour might have improved, other non-medication coping skills may have been implemented. In some cases, medication, especially polypharmacy, can make behaviour worse in the long term. There is a lot of side effects of drugs in the long term, things like sexual side effects, which we know can persist even after stopping. The TGA has put out a warning about post-SSRI sexual dysfunction now. Emotional numbing is very common. Fatigue, impaired memory, concentration issues, insomnia, and even worsening mood. Weight gain, much wasn't found in short-term studies, but is clear in longer-term studies, especially for drugs like mirtazapine. And in longer-term studies, antidepressant use has been connected to an increase in many physical health issues, such as strokes, obesity, falls, cardiovascular disease, osteoporosis, and even premature mortality, especially in older people. For antipsychotics, long-term harms include movement disorders, things like tardive dyskinesia, metabolic effects, probably linked to early mortality, reduced grey matter over time. There's evidence that antipsychotics themselves cause shrinkage of the cerebral cortex, and even long-term negative effects on functioning and recovery, as well as many subjective psychological negative effects. It's worth spending a bit of time talking about barriers to deprescribing when it's indicated. So many people in the public and also clinicians still believe that depression and other mental health conditions are caused by a chemical imbalance that can be corrected by medication. And we know that people that believe that, even if the medication is no longer indicated, are less likely to stop it. There are other models around for how antidepressants might work, affecting inflammation or neurogenesis, none of which have been shown in clinical studies. A lot of them are derived from animal studies, and there are much more obvious explanations for how psychiatric drugs work. You've heard them mentioned by everybody that's talked so far, which is a drug like an antidepressant clearly has emotional blunting effects. If you're very anxious, if you're panicked, if you're depressed, and the volume is turned down from a 10 to a 3, it can be a great relief, but that is very different from it fixing the underlying chemical issue in depression. And I think people should be aware that that is the most plausible way in which medications like this work. There's a very useful model, I think, called the drug-centered model, which is there are different ways of understanding how psychiatric drugs work. They're often presented as working by fixing underlying chemical problems, a little bit like insulin fixes diabetes, which is a message that's often given to patients, which I think is very misleading because that is not supported by good evidence. Another way of thinking about how psychiatric drugs work is they are psychoactive drugs, they cross the blood-brain barrier, they change the way we think and feel, and those effects are superimposed on underlying conditions, much more similar to the way that alcohol, for example, improves anxiety. If you drink alcohol, you feel more relaxed, you feel less inhibited. Nobody thinks that alcohol is reversing the underlying cause of anxiety or that anxiety results from an alcohol deficiency. We all understand that these effects are being superimposed on a condition, and it is much more plausible that psychiatric drugs work in that way, which means they can be very helpful. If you've got terrible symptoms, having them suppressed can be useful, but in the same way as these drugs have off-target effects, they wear off over time because of tolerance. They can have long-term toxic effects. They can also have more. They can also produce more harm than benefit in the long term. And some of those impairments I've talked about already. So there are two main barriers to reducing the use of psychiatric drugs. One is a return of an underlying condition that's been suppressed by the drugs, and the second is withdrawal effects. There's been wide discussion, of course, of underlying conditions coming back, so I'm going to focus on withdrawal effects in my talk, which relates to all classes of psychiatric drugs. So they've been mentioned that doctors don't understand what's going on, and I think that's true. It's not doctors' faults. It's because of guidelines for many years have given the message that these are not major issues. So most guidelines say something along the lines of discontinuation symptoms, itself a euphemism, are usually mild and last a week or two. And that description comes from studies of people who've been on antidepressants for 8 to 12 weeks. And that is true that most of those people do experience mild and brief symptoms. Not everybody, but as we'll see, the longer you're on medications, the harder it is to stop, the more your brain is adapted to them, the more severe the withdrawal effects. So to me, it's a little bit analogous to a car company crashing a car into a wall at 5 kilometres an hour and saying it's safe, and ignoring the fact that people are driving around at 60 or 80 kilometres an hour. And for long-term users, withdrawal effects are much more severe. In Australia, for example, the average user of antidepressants has used them for 4 years, so a far cry from the 8 weeks in these regulatory studies. Even the term discontinuation symptoms underplays the severity of the condition. To me, it's a little bit like describing a car crash as a discontinuation event involving a wall. It really takes away the effect. And you've heard people talk about the experience, which can be life-changing in real life. Current guidance in Australia essentially says gradually reduce the dose of these drugs over about 4 weeks. There's been an update to therapeutic guidelines saying take a few more weeks, but it's still talking about weeks. This guidance was based on a single study that showed that stopping these drugs abruptly causes too severe withdrawal effects. So the committee at the time decided that 4 weeks made sense. In other words, this was not based on any research. It is the most common approach taken in practice. We've surveyed patients. They're normally told to halve their drugs for a couple of weeks, halve it again and then stop it. Recent trials have found that that doesn't work for most patients, for long-term users. It may work for short-term users. It leaves at least half of people trapped on their drugs with this approach because it's intolerable for people to stop in this way. There's even less guidance for other drugs other than antidepressants. One consequence of this, which has also been mentioned, is people exit. These are people that are well enough, so this is sort of middle-class educated people, exit the health system and go into online peer support forums to get advice. These are a couple of sites. They're American. They get about 1 million hits a month. 6% of people on these sites are Australian public health patients, and the story is basically the same for these tens of thousands of different posts. I was told to come off these drugs over a few weeks by my doctor. The effects were so severe that I either ended up in hospital or I ended up back on the drug. The doctor told me this couldn't be withdrawal, it must be my underlying condition, and therefore I need this drug long term. But what I experienced coming off these drugs was nothing like my original condition. I had panic attacks for the first time in my life, I was dizzy, I had brain zaps, so I don't think my doctor knows what he's talking about. That's why I'm on this website, and these websites tell people to come off at about 10% of their most recent dose every month, which means the doses get smaller and smaller. 10% of 100 milligrams is 10, and by the time you get down to 20 milligrams, you're going down at 2 milligrams a month. And that advice has made the process a lot easier, not a walk in the park, but a lot easier than what my doctor told me. This is my only slide about neurobiology. I apologise. The main point here is this is looking at the effect of an antidepressant on a serotonin synapse, the connection between two nerve cells. The essence of it is that an antidepressant increases serotonin in between nerve cells by blocking the plug in a bath. You get more serotonin. That is like putting down the accelerator on a car. In response to that, the body is guided by the principle of homeostasis. We like to stay in the middle. When it's too hot outside, we sweat. When it's too cold outside, we shiver. When these receptors are bombarded by more serotonin, they downregulate, they reduce in number and sensitivity. And so the body puts the brake on to have a bit of balance while you're on the drugs. When you stop the drugs, the antidepressant is eliminated from your body by the liver and kidneys over a few days or weeks. The plug is working normally again. But what doesn't just reverse very quickly is the brake. So we can see from neuroimaging that, for example, serotonin receptors are changed for up to 4 years after people stop long-term antidepressants. In animal studies, we can see there are hormonal changes and serotonin changes that persist for more than a year after stopping. And so now you have a situation of the brake is on, the accelerator is off, and the whole system is now disturbed. And that is probably broadly what causes withdrawal effects from these drugs. It also brings up a point about how long these effects can last for. So people are often told by doctors, you've come in 2 months after you come off your drugs, this couldn't possibly be withdrawal effects anymore because the drug is out of your system. But that's a misunderstanding of what causes withdrawal effects. It's the time it takes for the brake to be let off by the body that explains how long withdrawal effects can last. So if it takes a year or 4 years for the brake to go back to how it was before the drugs were there, to return to its factory settings, if you will, then withdrawal effects can last that long. And this protracted withdrawal syndrome, that's the technical name for these things, have been identified for all psychiatric drug classes to have these long-term effects after stopping. A quick analogy is something like going to a loud concert. If you go into a loud concert, your eardrums become less sensitive to sound. When you walk out into the quiet street afterwards, your friends' voices sound muffled for a minute or two. It's actually a sound withdrawal syndrome. And it occurs because your eardrums take a minute or two to relax after stopping. So although the stimulus, the sound, dissipates in a second when you shut the door on the concert, it's the time taken for your brain to readapt to normal circumstances that explains how long the withdrawal effects can last for. And the same is true, of course, for exposure to antidepressants and other psychiatric drugs. The same is true for antipsychotics. Antipsychotics tend to reduce the effect of dopamine, so it's like applying the brake. Again, correspondingly, the body puts on the accelerator. It makes dopamine receptors more sensitive to the drug, to dopamine. When you stop the drug, you've now taken off the accelerator, or you've taken off the brake, and you're left with the accelerator. And so it's the same as if people have more dopamine in their system. And for example, taking a drug like speed increases dopamine. And so now, as a withdrawal effect from antipsychotics, you can have this pro-psychotic, pro-agitation, sort of insomnia type of picture, which can look like people's behavior has gone off, they're more agitated, and it can make people think, well, this person must need their drug because without it, they're more agitated, when it may be a temporary withdrawal effect that could have been mitigated by coming off the drug much more slowly. In this case, letting the brake down much more gradually whilst the accelerator resolves as the body becomes more accustomed to the drug not being there. So psychiatric drug withdrawal symptoms or syndrome are physiological symptoms that occur on stopping or reducing the dose of an antidepressant or any other psychiatric drug. They can manifest either psychologically or physically because these drugs affect so many different organ systems in the body. They affect the brain, the peripheral nervous system, the gut, the hormonal system, and they occur because, as I've just shown you, changes or adaptation to the brain caused by the drug take time to resolve. And withdrawal symptoms do not require addiction. I think it's another misconception. People think addicts, withdrawal, addiction involves compulsion and craving, which is not relevant for antidepressants and most psychiatric drugs. But all you need for withdrawal is adaptation of the brain to the drug, which is often called physical dependence, although those terms have unfortunately become conflated when discussed dependence and addiction, but they're different. For example, looking at people milling around before the lecture, I assume that almost everybody in this room is physically dependent on caffeine. But nobody is stealing or injecting caffeine, because addiction is not an issue. But if you were to stop using caffeine, you'd all go through withdrawal syndrome, not a particularly severe one, because you're physically dependent, in the same way as people using antidepressants or antipsychotics for several weeks are also physically dependent but not addicted. And of course, the flip side to withdrawal is tolerance. The more tolerant you are to a drug, the more you get withdrawal from it. This is often downplayed for psychiatric drugs, but of course, tolerance is an issue for all psychiatric drugs. In America, our more colourful colleagues use the term poop out to describe this phenomenon. So just to go through, a lot of what I talk about for antidepressants is true for all psychiatric drugs. There's a lot of overlap between the different syndromes. I'm going to go through this one. There are a lot of different symptoms. To some degree, when I see a new symptom that comes up after people stop a drug, I assume it's the drug until proven otherwise, because there are just so many systems affected. Dizziness, insomnia, impaired concentration, fatigue, headache, tremor, tachycardia, nightmares. There are mood symptoms, depressed mood, anxiety, panic attacks. We know that these are not just a return of people's underlying condition, because they are found in studies where people do not have underlying mental health conditions. In studies where people are given the drugs for the menopause, for pain, or even with healthy volunteers, they all demonstrate these symptoms on stopping. There are some quite distinctive sensory symptoms that have been described already, brain zaps. There are gut symptoms because there are so many serotonergic receptors in the gut. There's an increase in suicide attempts in the weeks after stopping an antidepressant that has been attributed to withdrawal because it's too soon for relapse. And I'll show you a study where we try to identify that. Couple of slides, and I think akathisia, is something that has been very much overlooked. Akathisia is recognised as a long-term side effect of antipsychotic use, but akathisia can also be caused by coming off antidepressants and other psychiatric drugs. These are the sickest patients that I see. They describe feeling terrorised, they're agitated, they're often pacing, although not always. Sometimes they describe it as this sort of internal agitation and terror. They've described it as feeling like their nervous system is on fire, and there's a high risk of suicide because these people just do not get a moment of break from weeks at a time. Most clinicians are not aware that withdrawals can cause akathisia, and they are often misdiagnosed as agitated depression, mania, or even psychosis. And I'm sure in the context of behavioural disturbance as a return of an underlying behavioural issue. So antipsychotic withdrawal symptoms, again, a lot of overlap, insomnia, movement disorders, dizziness. People can develop psychotic symptoms on coming off antipsychotics. We know that in people that are given antipsychotics for things like trouble with lactation, so women without any mental health problems can develop psychotic symptoms on coming off antipsychotics. And so this leads to all sorts of misdiagnosis when people attribute the issues that come up when they stop antipsychotics to an underlying condition rather than to withdrawal effects. So how common, severe, and long-lasting are these symptoms? There are a few different meta-analyses out now. I think the most interesting aspect of them is the relationship between duration of use and your risk of withdrawal effects. So on this graph, here on the right side, you can see that the longer you take an antidepressant, the more likely you are to have withdrawal effects. That's the top line. And the more likely those effects are to be moderately severe or severe. So a lot of drug company studies, including a very recent high-profile Lancet meta-analysis, looked at the bottom, at people that have been using the drugs for a few months, and then withdrawal effects are uncommon. 1/3 of people, not completely uncommon, but less common, and they're generally mild. But by the time you're using these drugs for years, most people are having withdrawal effects when they stop, and half of them are having severe withdrawal effects when they stop. And that's true, and that trend is true for all psychiatric drugs. The longer you use them, the harder it is to stop, the more severe the withdrawal syndrome. I mentioned this already, that there's misdiagnosis that is rampant when clinicians are not aware of these issues and they misdiagnose a return of an underlying condition. There are now about 200,000 people on these peer support sites getting advice on how to come off. We surveyed about 1,000 of them. They said this was their main reason for being there, because they had all been misdiagnosed by their clinicians. It's extremely easy to understand why that would happen when clinicians have been educated for decades that withdrawal effects are mild and brief, and people come into their office or to the emergency department with severe, long-lasting symptoms. It's of course understandable they're going to flick on to relapse rather than withdrawal. And of course, these more severe presentations can be very quickly misdiagnosed as mania, psychosis, severe behavioural difficulties. There are a few clues to help distinguish withdrawal from relapse. In general, withdrawal effects have quicker onset. They happen a few days after reducing or stopping a drug, but they can be delayed by weeks. When I first saw that, I thought that was very strange. You know, the textbooks say it should take 3 to 5 half-lives for withdrawal effects to manifest. I don't know what the biology of it is. I imagine it must be something to do with the accumulation of effects building to a threshold, but people can have delayed onset of withdrawal effects. Specific symptoms help to distinguish withdrawal from relapse. So things like dizziness and electric shock sensations are clearly distinctive from anxiety and depression, but really any symptom, and psychological symptoms are very common in withdrawal, that is distinct or more severe than the underlying condition should also be a bit of a tip-off. So for example, if someone went on a drug because they were depressed, lethargic, not sleeping after the death of a loved one, and now a few years later when they come off the drug, they're agitated, they can't sleep, they're anxious, it's much more likely they're experiencing quite common withdrawal effects than coincidentally developed a new onset panic disorder that just happened to occur the moment they stop their medication, although you'd be surprised at how often that sort of diagnosis is made. Often, if the drug is restarted, there's quick resolution, except if you delay reinstatement of the drug, in which case results are much more unpredictable. And there are all sorts of misdiagnoses that happen when people are sent to neurologists or other physicians when they have fatigue or funny neurological symptoms like jerking movements, which are common in withdrawal. They can get diagnosis of medically unexplained symptoms, functional neurological disorder, chronic fatigue syndrome, or other neurological psychiatric conditions. So maybe just briefly, there is more recognition, I think, of dizziness and anxiety coming off these drugs, but there's still a lack of an appreciation for how long-lasting and severe these issues can be. This protracted withdrawal syndrome. We tried to distinguish this in this survey. We asked people in this table, what symptoms did you have before you started the drugs? And you can see lots of people were anxious and depressed, and some of them were suicidal, 3 out of 10. And what did you have when you stopped the drugs? And you can see there's a huge uptick in symptoms. Although 3 out of 10 people were suicidal before starting the drugs, 6 out of 10 were suicidal after stopping the drugs. In other words, 30% of people experienced new onset suicidality from stopping the drugs. You can see akathisia is hugely increased. In fact, all of the symptoms were increased. I didn't show severity here, but they're also much more severe symptoms than what happened before. So these are, although there is overlap, these are increased in severity and in number. And because of very little recognition of this protracted withdrawal syndrome, which can last months, for some people for years, I think of it much more as an injury to the nervous system caused by coming off the drugs, because sometimes going back on the drugs does not fix the issue. And when you hear people with neurological, somatic, psychological symptoms that make it difficult for them to work or to fulfill their social roles, it really does look like something to me as severe, if not more so, than multiple sclerosis or something along those lines. Analogy is to long COVID, although I think it's more severe. It's worth noting that long COVID, first of all, people thought that can't happen. How can a short-term virus cause long-term issues? It was picked up much more quickly because it was so widespread and because doctors were affected. That hasn't been true as much for protracted withdrawal syndromes from psychiatric drugs, and that means that a lot of people are left to fend for themselves with family and friends trying to step in because the medical system doesn't recognise what's going on with these people. So if that's the problem, I want to talk a bit about the solution, how to minimise the issues coming off these drugs. So I'm going to start by going through guidance put out by the Royal College of Psychiatrists in the UK, which I think is far ahead of anything in Australia, which outlines a few broad principles. It says the following things. For long-term users of antidepressants, which means people have been on the drugs for months or longer, coming off can take months or years. They suggest going down to very small doses, sometimes less than 1 milligram for long-term users before stopping. And they recommend going down in smaller and smaller size reductions, and that the rate should be adjusted to the individual's ability to tolerate the process. So some of those things probably sound a bit strange. I'll try and make sense of where they come from. So we published this article in the Lancet Psychiatry a few years ago, highlighting the relationship between doses of antidepressant and other psychiatric drugs and effect on the brain. And the main, so this is neuroimaging, this happens to be of people on citalopram. The main point is that the relationship between dose of a drug and its effect on target receptors in the brain is not a straight line. So doubling the dose of a drug doesn't double the effect. So 40 milligrams of citalopram doesn't have double the effect of 20 milligrams. In fact, there's not that big a difference. And a tiny dose, say 2 milligrams, actually has about half the effect of 40 milligrams, much more than you would think. And this is because of the law of mass action, which basically says when there's not much drug in the system, all the receptors for the drug are unsaturated, open for business. And every milligram of drug has a large effect. And as you have more and more drug in the system, more and more receptors are occupied, and so every extra milligram has less and less effect, a bit like the game of musical chairs. Beginning, it's easy to find a chair. At the end, it's much harder. And so you get this law of diminishing returns. That helps us to understand what happens when the advice given by most clinicians is followed when people come off their drugs. So a kind of common way of reducing drugs might be go from 20 to 10 to 5 to 0. It's very easy to do with tablets. 20 milligram tablet, halve it, give it 10, give the 10 every second day. Very simple for the clinicians to implement. Very hard on the patients. Because when you go from 20 milligrams to 10 milligrams, there's a small change in effect on the brain if you look at the y-axis. Going from 10 to 5 is a bit bigger again. Some people find that very unpleasant, but some people can tolerate that. But going from 5 to 0 is like jumping off a cliff. It has about 15-fold the effect of going from 20 to 15 milligrams. And it's exactly what patients describe. The first few milligrams are easy to come off, the last few milligrams are hellish. And when clinicians are not aware of this relationship, they think, well, the person must need the drug, they're in pieces, and they don't understand that what's happened is they've just had a huge change in their neurochemistry from these changes in the drug. So what makes more sense is rather than reducing by even amounts of dose, is to reduce by even amounts of effect on the brain. And so I've drawn 4 horizontal lines separated by 20 percentage points on the y-axis. And that corresponds to smaller and smaller size reductions in terms of dose on the x-axis. And because this graph is called a hyperbola, if you remember back to high school maths, this has been described as hyperbolic tapering, smaller and smaller such reductions. And the final dose before stopping in this example is 0.8 milligrams. So that final reduction to 0 doesn't cause a bigger change in effect on the brain as the previous reduction. So much, much smaller than commonly available tablets. A simpler way of explaining this, if you're giving an elevator pitch to a patient, is if you reduce dose by a proportion of the most recent dose. So for example, if you reduce dose by 50% per month, 20, 10, 5, 2.5, 1 1/4, 0.6, it produces roughly even changes in effect on the brain. Some people find that rate of reduction too fast, too unpleasant, and it's better to introduce intermediate steps, say 25% per month, or even 10% of their last dose per month. I think it's no coincidence that people on these online peer support forums that I mentioned have, through trial and error, worked out an identical solution to what matches the neurobiology of the effect of the drugs on the brain. I think that's no coincidence. That they've had to do it themselves through trial and error and come to the same solution. What I've just said for citalopram is true for all antidepressants, and it's true for all psychiatric drugs. That the smallest available tablet or capsule, which I put a red line for fluoxetine, for venlafaxine, for sertraline, for paroxetine, has a huge effect on the brain. People are often told you're on a very small dose, and that is almost always false, because what people are saying is you're on the smallest available tablet or capsule, but the brain doesn't care about the size of the capsule or the tablet. What it cares about is the effect on receptors. So most people who are stopped at 37.5 milligrams of venlafaxine or 20-paroxetine are being pushed off a cliff and they fall to pieces because they need to be taken down this cliff much more slowly. There is now emerging evidence that this approach works better. There's a randomised controlled trial taking place in Queensland. There are several cohort studies looking at people who have tried to come off antidepressants using the regular approach, halving again, stopping, and most of those people cannot come off their drugs. When they are provided with medications that allow them to make these smaller reductions, to go from 20 to 19.5 to 19, all the way down to a milligram of drug, hypololic taper taking many months, most of these people can come off their medications. And when they're asked, how severe were your withdrawal effects in the traditional way, most of them say it was 7 out of 7 terrible withdrawal effects. When they come off in this slower way, most of them say it was 2 out of 7 relatively tolerable. The Royal College of Psychiatrists has a few general pointers. It recommends adjusting the rate of reduction to what a patient can tolerate. I'll talk about a few risk factors, but it's really what it comes down to is what is the patient experiencing, because we don't really have enough research to know what the right rate is for every patient. If withdrawal effects become too severe, either stop the reduction, go back a step or two, go down more slowly to find the right rate. And they also now recommend this 10% per month of the most recent dose as a good starting point. They give some examples. This is an example that I would consider relatively quick for someone who've been on the drug, say, for a few months for citalopram, going down to very small doses, often using a liquid version of the drug. And here is one for a drug that's harder to come off, like paroxetine, taking really 2 or 3 years, going down at 10% of the most recent dose every month, using a liquid. At the bottom, there's actually 30 more steps in one of those boxes. And in my clinic that I run in London, we certainly see people taking 2 or 3 years or longer to come off these drugs. That's not at all unusual. So the question that always comes up in practical terms is, how do you do this in practice? And that is a major barrier. There are ways around it. So tablet cutters can be useful at the beginning to get half or quarter doses, but at some point that will not be enough. Liquid preparations of the drug can be useful. In Australia, it happens that escitalopram is the most commonly used antidepressant, and it's the only drug that comes as a liquid, which makes it a bit useful. It comes as a dropper. You can dilute the drops in water. You can open the dropper and use a syringe to make small doses. There are ways to do it. Your local friendly pharmacist is probably a useful person to have around when doing this. Doctors and other clinicians try to simulate what I've just said by skipping doses. Try it every second day, every third day, every fourth day. That is not a very good idea, because the half-life of most antidepressants and other psychiatric drugs is 24 hours or less. It means you get wildly swinging levels in your blood, and people can have severe withdrawal effects from that approach. The exception are drugs that have much longer half-lives, like fluoxetine. That gives you a little bit of leeway. But I should say something about fluoxetine. The manufacturer put a lot of money into presenting it as an issue, as a drug that doesn't cause withdrawal effects. And the way they did that was they stopped all these drugs for a week and showed that withdrawal effects didn't occur for fluoxetine, which is very misleading because it takes several weeks for fluoxetine to leave the blood. And so it gives people the false impression that fluoxetine is self-tapering, and guidelines in Australia still say that. I see huge trouble with fluoxetine. Half the people who come off the drugs have trouble from trials, and so fluoxetine is not a free ride. You might trial it, but it's something that needs to be tapered in a similar way over months or longer. It's not a free ride out of there. There are also off-label options. So for people that cannot swallow tablets or capsules, this is guidance from the NHS. I'm sure there's equivalent guidance in Australia. For children, for old people, it is fairly common practice to crush up a tablet, mix it in water. It makes a suspension, not a solution, so you need to shake it round, like any cough syrup that says, shake before use. We use this in our clinic when drugs are not available as liquids. For example, you can take almost any tablet of a drug, crush it up, mix it with 200 mils of water, and get people to take away 1 mil every day and slow it down if people are having trouble. That way you can take any tablet and reduce it over a few months as a simple way to implement it. I think that an important step forward here in Australia would be to make manufacturers produce drugs in doses that allow them to be stopped. In some ways, it's absurd that doesn't happen. To me, that's like producing cars without brakes. I think it should be, mandated by the TGA that if you're going to put a drug on the market, you have to make it available in a form that makes it practical to stop. Just a few examples to put things in people's minds about what can be done now. Mirtazapine comes as a dispersible tablet, so it's designed to mix up in water. You can put a 50 milligram tablet in 150 mils of water, take away a meal or two every day or every week. I've mentioned escitalopram. Compounding pharmacies can make any drug into a smaller tablet, capsule, or liquid. There are financial implications. I think you should think about the long-term effects of people on drugs they don't need, with all sorts of health consequences to work out whether that makes sense or not. Drugs like venlafaxine and duloxetine require you can open up these capsules and count or weigh beads. It is a bit absurd that people are forced to become Walter White-like figures to come off these drugs, but there is no other way if the lowest dose of a capsule has almost the same effect as 10 times that dose. So people are forced into this. We wrote this textbook to put everything I've just explained into one place. Explains how to distinguish withdrawal from relapse. It gives reduction schemes for every antidepressant, benzodiazepine, Z-drug and gabapentinoid licensed in Australia, slow, moderate and fast versions, how to adjust it to an individual, which formulations of drug to use. We give examples on how to work out people's risk, to work out what rate to go at, what doses to use, what forms of drug for a slow version, for a slower version. And I'll just quickly say, everything I've just said for antidepressants is true for antipsychotics. Small tablets have large effects for antipsychotics. The smallest available tablet has a much bigger effect than you would think for haloperidol, for risperidone, for all again, tapering rate of 5 to 10% per month makes sense for almost all psychiatric drugs. Same is true for benzodiazepines, for diazepam. So these are the sort of regimes that we suggest, and the same for pregabalin and gabapentin, which is becoming a very big issue in the UK now with increasing deaths, unintentional overdoses from these drugs, and everything. And it's actually true for all different psychiatric drugs. And you can get a free copy of the Maudsley if you're a GP, made available through the Royal College of General Practice, and otherwise there's a bit of a discount code for other practitioners. Pharmacists can get if you're a member of, which is the right, which one? PSA, there we go. So through the PSA, you can go to the PSA website and get a free version through there. Thank you. I'll stop there. Happy to take questions at the later session. Thanks very much.
Thank you so much for that, Mark. And as you were talking, there were two things that struck me. You followed up Tammy's beautiful lived experience with the montage of people with lived experience, and they were able to articulate with deep depth of experience what that actually felt like. And what struck me is, what must it feel like to be a person with disability, a person with a cognitive impairment, a person who is non-verbal and experiencing the terror, the restlessness, the akathisia, because that's what the people in this room are working to support every day. So suddenly those experiences that you've just talked about this morning take on that next layer when we are supporting people who may not be able to articulate their experience in the same way. The second thing that really struck me is the challenges of people who have been on these medications for years and years. So it seems to raise the question, which is, how do we get there in the first place? And is there a question that starts beyond coming off the medications, which is actually being put on the medications in the first place? We can't have a conversation about effective deprescribing unless we are talking about effective prescribing. And that leads us to our next speaker, Professor Julian Troller. Professor Troller is the inaugural director of the National Centre of Excellence in Intellectual Disability Health. He is a neuropsychiatrist, NHMRC Leadership Fellow, and he founded the Department of Developmental Disability founded the Centre for Developmental Disability and Neuropsychiatry at the University of New South Wales. He is a keen educator, developing curriculum, frameworks and models of care for intellectual disability health. His research program spans national health services evaluation, policy analysis, data linkage and clinical neuroscience. He's been recognised internationally for his research and his clinical work, advancing the development of new knowledge to improve the lives of people with intellectual and developmental disabilities. Most recently, in January 2025, he was appointed a member of the Order of Australia for his significant service to people with disability as a clinician and an academic. Please welcome Professor Julian Troller.
Thank you, Trin. I promise I didn't write that. I'm not sure who did. Apologies for it. I'd like to acknowledge the Kaurna people, the traditional custodians of land here in Adelaide. I work on the land of the Bidjigal people, the traditional custodians of UNSW Sydney, and I'd like to pay my respects to elders past and present and First Nations people present today, and acknowledge the significance of cognitive disability for First Nations people across our country. I'd also like to acknowledge people with lived experience of disability and those who support them, including people present today. And I think this is it's very important that we're coming together today to discuss this topic. I acknowledge the great expertise in the room, and it's been incredible already to hear from Mark. I'd like to acknowledge the Commissioner. I'm sorry I walked in as you were speaking and I caught some of what you said. And I'm very grateful for your perspective and the lens that you bring in your work to this issue. And I'd like to thank the Restrictive Practices Unit for this invitation as we try and work together to make things better. Obviously, prescribing and deprescribing and the clinical care and support of people with cognitive disability requires all of us to be working in a cohesive way, but we currently lack really good models of support to do that effectively. So we're sort of stuck a little bit in our silos, but it's great to come together, and I'm sure we'll have lots of good discussion on how we can progress more integrated models of care. I have some funding acknowledgements. Obviously, these are really important for us. Particularly funding from the Australian Government Department of Health and Aged Care for the National Centre, a great initiative under the new National Roadmap, not so new now, to improve the health of people with intellectual disability. And I'd like to acknowledge that some of the data work I present requires great expertise and people to help us link that data, and so they're acknowledged too at the bottom of the slide. Today I wanted to talk a little bit about the landscape in which we're in here in Australia and the pressures, I think, and the exciting opportunities to do things differently. Talk a little bit about the issue of the health needs of people with intellectual disability. Talk a bit about how to prescribe well. I don't know everything in this area. I'm sure there are many experts here who could give a better description on how to do this than me. Talk about some of the challenging areas that I see, and talk about some resources and next steps. And then I hope to have this fantastic discussion with you after the session. We have had recently in Australia the Royal Commission into Violence, Abuse, Neglect and Exploitation of People with Disability. It's a scandalous finding that a commission could make a finding of systemic neglect in the Australian healthcare system. And, you know, we have a well-developed first-rate health system, yet we find ourselves in a position for those with cognitive disability of providing care that is labelled systemically neglecting of their needs. And in particular, some aspects of prescribing came into view in some of what the Commission talked about. Obviously, the public hearing number 6 found that prescription of psychotropic medication is failing to adequately protect people with disability. And there are a number of different findings around things that are important to consider in the prescribing cascade, or the cascade in terms of how we do this well including research data gaps, performance indicator gaps, and that we're not monitoring and really routinely reporting these issues, and professionals' lack of training in the area across all health professionals. But of course, there are a number of key recommendations here on the right side that are very important for us to consider, whether we're a regulator, a person working in a government setting, a policy person, a health services person, a person working within a practice. There are all sorts of recommendations that speak to our need and help us understand how we could do things differently across the range of recommendations in Volume 6. And if you're like me, I'm sure you've read all of these volumes with intense interest, and I've tried to summarise them there. During the life of the Commission, the Australian Commission on the Safety and Quality in Healthcare, which is really our regulator of standards in healthcare, together with the Commission relating to aged care and the NDIS Quality and Safeguards Commission, issued this joint statement. And I think this is very helpful, preemptive action to help us think about how we could be better using psychotropic medications in the management and support of behavioural difficulties in people with disability and older people. And I commend that to you as something helpful to read. I'm not quite sure why defining the problem is so huge. Perhaps that's because of the scale of the problem. I have no idea how that happened. It's exciting, isn't it, to see just what happens with the slides when they're sent remotely. So let's have a look at what the problem is. I think one of the issues that strikes me in thinking about a population is we often talk about it as something of uniformity, and people with intellectual disability are all different. The variety is and the diversity of the population and their needs in the healthcare space is incredible, with very variable abilities, complexity of the physical health issues. So the importance of things like the etiology of the disability, the social determinants of health that that person experiences, the diversity of their interactions with support systems around them, and their health literacy and access to resources to support healthcare journeys. And I think all of these things shape the important principle that I think Mark alluded to, that really we must be person-centred in the way we approach things. Everybody is different. We're all different biologically. We're all different in our interoceptive experiences, how we pay attention to our bodily sensations. And so this means that when we're prescribing or withdrawing medication, this requires a personalised approach to medicine. People with intellectual disability are also complex in their health needs, and there are overrepresentation of health needs in almost every bodily system. And so some of these revolve around the brain, including particularly high prevalence of things like epilepsy, which of course are also important predictors of whether or not you develop a mental health or a behavioural problem if you're a person living with intellectual disability. We did this systematic review. My wonderful PhD student, now staff member, Peiwen Lau, led this. And this is a useful thing if you're wanting the summarised evidence on the incidence and prevalence of different health conditions in people with intellectual disability, but it shows us really what was on the previous graphic. Some of the important health indicators, I think, for people with intellectual disability, just summarised on this slide to help us set the scene. Median age at death, 27 years younger than the general population, but causes of death similar to the general population. More than 38% of these deaths are potentially avoidable by a standard statistical definition. That's double the proportion in our general population. Interestingly, having a serious mental illness increases your risk of death by 4 times, and there's a higher risk of death in people with intellectual disability living with cerebral palsy, epilepsy and Down syndrome. And so some of our publications are listed there. If you get access to the slides, you can click on those links. We also have a problem with failure in our healthcare system, so that people present more often with potentially preventable conditions to hospital, and when they're admitted, they come back more often to hospital because treatment within a hospital setting has not been tailored to the person's needs, and so it fails the person and they come back for the same condition at a higher rate. So the readmission rates are very high when we've looked at physical health conditions, epilepsy, even first admission for epilepsy, or mental health conditions or other conditions. And we also see people coming to emergency department and for all sorts of admissions at much higher rates than the general population, generally double, 2 to 3, depending on the health system we're talking about. So essentially we're seeing health disadvantage across a lifespan, which begins very early in life, and essentially means that frailty is brought forward on average 25 years and premature death on average 27 years. And this represents a lifelong health disadvantage. So we have to think about this lifespan perspective in healthcare, including prescribing. Prescribing starts incredibly young in the sort of people we're thinking about today, much younger, particularly with psychotropic medications than the general population. And I'll show some data that might help us understand that. Within this whole of health context then, we need to understand that mental health conditions are very, very common, 2 to 3 times the prevalence of the general population. These are some of our data that are accepted for publication, shortly will appear in the Australian and New Zealand Journal of Psychiatry, just showing the prevalence rates of any psychiatric condition, which in our population-based cohort in New South Wales is 76% of all people with intellectual disability, compared to 38% of a matched control group. So it's matched for age, sex, socioeconomic status, rurality. Okay, so it's really a stark contrast, including for serious mental illness. And I'm hoping I can show, I'm not sure if the pointer works, but you can see the second row there for serious mental illness, the prevalence in people with intellectual disability, 16% compared to 5% in the general population. Right down to psychotic disorders with an overrepresentation, 4-fold, self-injury and suicidality 3 times as high, dementia more than 4 times as common. So you can see right across the board in all major classification categories of mental illness, we see very high prevalence rates for this group. Now, what are psychotropic medications? We need to come to a shared understanding. I think this audience will know that they're medicines that affect our mind, emotions or behaviour. They're used usually to treat mental health conditions and sometimes in the context of behavioural support for people with intellectual and developmental disabilities. And there are 3 main groups. Now, we usually focus on psychotropics when we're thinking of good prescribing in this context, but I think we need to keep in mind prescribing as a whole because we have problems with prescribing as a whole, and I'll come to this. My sense here as a clinician and as someone who's looked at data is that we also need to think about prescribing as a balancing act. We know that people with intellectual disability have major barriers to access to really good quality healthcare. And sometimes this means they don't get the care that they need, including medication management of key diseases. And I'll show you some data in a wee while. And so we have a balancing act. We have medications that need to be prescribed and they should be as accessible as they are to the general public, yet we know that they're not. We have a group with very high prevalence of certain conditions that should be amenable to preventive action during the life course or action such as access to mental health medications. Yet we have very high prevalence of some of those conditions, and we know that people with intellectual disability are also at higher risk of harms associated with medications, particularly psychotropic medicines. And so this is a really fine balancing act, one in which I think we need a very nuanced story around the health needs of the person and not a general blanket concern about ever access to medication for people. We must do it in a nuanced and balanced way to ensure that the person is able to access treatment that they need that supports better health care. So we do know that sometimes medications are indicated as a primary treatment, yet and are responsibly prescribed, but sometimes we know on the right-hand side they are inappropriately prescribed, poorly monitored and reviewed, not commenced when needed, not stopped when they should be, and not reflective of current practices. And I think that's where our evaluation needs to be really confidently made. We know that people with intellectual disability experience very high rates of psychotropic prescribing. Let me talk a little bit more about that. They also experience very high rates of polypharmacy, and that means multiple medications coming together that increase risk of poor outcomes, including side effects, hospitalisations, and for which there's little evidence. Well, I think Mark would actually be able to unpack that for us perhaps, but really no evidence that adding more and more medications gives an added clinical benefit whatsoever, but is associated with harm. The Royal Commission found that psychotropic medicines are overprescribed in people with cognitive disability and particularly overused as a response to behaviours of concern. Now, we looked at representative data in Australia from what was called the BEACH system, which was representative general practices across Australia, and analysed that and looked at people with and without intellectual disability and with and without autism. And what we found in that study was very, very high rates of prescribing, including for children with intellectual disability and autism. And startlingly, we also found less attention to preventative health prescribing. So we know that people with intellectual disability, for example, have very high rates of high blood pressure, obesity, diabetes, and so on. But we found prescription for these things was way lower than it should have been. We also saw a trend to use older style drugs in people with intellectual disability, so less access to less modern treatments, including for things like pain control, and less availability of access to analgesia. So there were some nuanced stories in this. Strikingly, we saw very high rates of psychotropic prescribing. An example was a 10-fold increase in antipsychotic prescribing for people with intellectual disability. Oh, okay, it looks like how to prescribe well is also a very big issue, so we'll move on to that. There are some general principles. I mean, I like to try and simplify things, but if we understand, we must start with understanding what the person's health needs are, taking into account the broader health needs and comorbidities. We must make sure that we have some good baseline monitoring. We must make sure we develop a plan. And that plan also should not just monitor the medication and set targets and monitor the medication efficacy, but it should monitor side effects, and that's a challenge in our population. We must minimise polypharmacy and monitor cardiometabolic risk in particular. There are some great ways I think we can think about doing this well. Thinking about what we need to do before we prescribe is really important. Do we know about the person's communication preferences? Do we know how they participate in consent and discussions about their health needs? Do we know all we need to know about their pharmacological history, or are we just repeating past failures and exposing them to harm? Do we know enough about their psychological status and their behavioural support plan? And is it our intention to integrate what we're doing with that plan? That's very important. Do we know enough about the sensory profiling and functional profiling of the person? Do we have all the details about the medical history? Often someone comes with a piecemeal medical history. And we obviously know in depth to assess psychiatric symptoms, but I can't tell you how often I've seen people for whom, in retrospect, the diagnosis was wrong. And one example strikes me as a young woman with intellectual disability and developmental disabilities who found herself on clozapine because it was presumed on the basis of her behaviour that she had a psychotic illness, and her behaviour settled very well. She's very well controlled with high-dose clozapine, as anyone would be. It took me more than 5 years in a steady, progressive manner to withdraw the clozapine, and she's now off clozapine. Fantastic. But she's struggling with the long-term impacts of clozapine, including significant weight gain. And in a sense, clozapine has been something that's been used as a bedrock of treatment where other building of her capacity to tolerate stressful situations and other difficulties in life and to deal with emotional dysregulation needed to be the focus all along. She's not become psychotic, and she doesn't have schizophrenia, as was the label. So we need to make sure we assess psychiatric symptoms well. Home medicine's reviews will come to, we need to be mindful of someone's nutrition, diet and physical activity, and know a lot about where they live and the supports they get and their medical comorbidities. We need to make sure when we're thinking about prescribing for mental health issues that we know enough about the risks that are more nuanced associated for that person, such as epilepsy. Many of our psychotropic medications reduce the seizure threshold, meaning that the person's seizure control may be upset, and that in turn worsens mental health in that person. So we wouldn't be wanting to do something that provokes that. And likewise, we can think about all of these domains, including things like the vulnerability to dementia for that person and choosing medications that are less likely to exacerbate the cognitive difficulties the person's experiencing. Comprehensive treatment planning needs to take place here. So, when we're thinking of prescribing, we need to be thinking about how our treatment impact will be measured. What are our targets? Do we know clearly what we're aiming to target in the medication management? Often that's not recorded or poorly thought through or not discussed with the person. Have we a contingency plan for if the medication is ineffective or the person's experiencing side effects? Have we got communication strategies that will enable the person to express how they're feeling on the medication and to be able to monitor effectively those adverse effects should they occur? And are we making sure we know clearly what the baseline for that person is to know whether the medication has been effective or not? And have we set clear timelines for the review of that medication to see whether it's been effective? So in commencing, those establishment of the person's baseline and probably a structured monitoring would be helpful. That we must make sure, particularly when we're prescribing for behaviour, as should be the case less often than more often, we should make sure we're always ensuring the person has access to appropriate, sophisticated behaviour support, and that what we're doing with the medication is included in the monitoring of in that behaviour support plan. If we're making decisions in isolation, just on the basis of reports that sit outside that comprehensive monitoring framework in a behaviour support plan, then we're not getting all of the information we need, and we're not then able to make sensible decisions about next steps in medication, whether that's to withdraw the medication, to increase it or change it. And I think an important safety principle with this group who are experiencing high risk of side effects is to start low and go slower in increase. Mark highlighted sometimes withdrawal of medication needs to be done very, very slowly, and I absolutely agree. I think for this group, particularly thinking of things like risk of tardive dyskinesia, which are higher in this group, we may even need to be more cautious in those who are living with cognitive disability when we withdraw medication. So how do we monitor well? Well, a person with intellectual disability may or may not be able to self-monitor and provide reliable information. Those around them often in the situation where a person needs support are often very clued in to bodily sensations and how they're expressed. And so we must make sure we're getting all of that information from those around them who would usually support the person in that way. We should ideally know what's normal for the person to experience before we start the medication. Without that baseline, it's very difficult. And we should only continue the treatment if there's evidence that is actually working. It's targeting the things that we set to be targeted. And that's really important. We often don't do that well. We need to think about medication side effects in two broad categories, both in terms of physical presentations of those side effects, our body metabolism and whether we're measuring that, extrapyramidal side effects, akathisia, cardiovascular health, and hormonal impacts. But we also need to be thinking about behavioural presentations of side effects. If you can't express things verbally, you may be more likely to show a behavioural equivalent, that you're uncomfortable, that you're experiencing restlessness, as is characteristic of akathisia. So we need to look for new onset behaviours and exacerbation of existing behaviours. Sometimes the fact that behaviours have got worse means that a clinician may think, oh, I'll increase the dose. It could actually be the akathisia driving that increase in behaviours. Baseline data is important. I think I've emphasised that. Clear targets for psychotropics, some metabolic screening, routinely, behavioural changes monitored by sleep and behavioural charts, and specific data based on the medication and the risk profile of the person. And subjective data can be obtained from the patient and the carer, and we need to be making sure we ask about side effects in an accessible way, in a way that works for the person, and sometimes that's not verbally. Home medicines reviews. How many of you are pharmacists? Woohoo, great. How many of you have done home medicines reviews? Great, it's fantastic. What a great asset. You know, these are funded both for for doctors to be involved in them and for pharmacists to conduct them. And they're not just once in, there is some leeway to follow up with actions. But this is an incredibly important type of review, I think, that can really help us and help connect us as well as we try and do things better. Help connect pharmacists who know a lot about profiles and interactions with doctors who know a lot about how to support the health needs of the person. What a great thing we have in our system. Sometimes, however, we need more highly specialised reviews. And I think we need to consider what context we might seek them. Some I've listed here, when symptoms don't get better or worsen with standard age-appropriate treatments, when there are complex presentations, say a person has a more severe disability, so communication challenges might be higher, or they have a complex genetic disorder where there may be a behavioural phenotype associated with that, and particular ambiguity around whether or not the presentation involves psychotic symptoms or not. Sometimes that can be very, very hard to judge. Where the nature of the problem is uncertain, even though we've done multiple assessments and we're still not sure, is this depression, is it not? Is it bipolar disorder, is it not? Sometimes we're uncertain and it's best to get a second opinion. And it's best not to initiate treatment when we're uncertain. Sometimes we're forced to action if there's very, very, very high risk for the person, and that's acknowledged. I think where the condition or treatment requires very specialised psychotherapeutic or pharmacological skills, where there's a deteriorating or unexpected course for the person, and where there's a continuing high risk to the person despite treatment, despite maximising the approach behaviourally and with medication. Gosh, it seems that every topic is a really big topic today. It's extraordinary. It's fascinating. More difficult areas. Could there be any more? Well, Mark has talked extensively about deprescribing, and I really support what he was saying about how we need to do this really carefully, and he's given lots of detail. What about pharmacological management of behaviours of concern? Who's concerned about that topic area? Could I just get a sense? Great. Okay, so it might be something we can take up more in the discussion sessions later, but the use of psychotropic medication for behaviours is very, very common, and unfortunately the evidence for effectiveness is limited. Now, it doesn't mean that there may not be times where it's helpful, but it means that the evidence and what we have so far suggests, is very little, firstly, and suggests limited effect. There are some exceptions. So I think in the absence of a clearly defined medical or psychiatric need, we need to be really careful to say when we should really think about prescribing. And this is, I think, where really comprehensive behaviour support in a sophisticated model has not worked when it's been tried, refined over a long time, and when the level of input has been escalated so that you've got expert behaviour support. I think also sometimes there's a good case where positive behaviour support has helped somewhat, but there are ongoing problems and ongoing high-risk issues, and we must really consider that medication can play a role in that context. Resources and next steps. I was hoping that would be in small text. Anyway, Resources for prescribing. These are some of ours that we've produced over time. You'll get the links. But, they include things like podcasts with experts talking about prescribing with children and adolescents and with adults. It links to things like articles that we've written and cardiometabolic resources. We're really fortunate to have developed an algorithm for all providers of support for people to reduce the risk of cardiometabolic diseases. Cardiometabolic diseases are the biggest single category of potentially avoidable deaths in people with intellectual disability. So we must do that better. We're going to update that by the end of the year. We've got a project team working on that now, which is wonderful. Our IDMH Connect web tool has lots of resources, largely New South Wales based, but it gives a clinical care pathway of how to go through and get support for people with intellectual disability. So it's an accessible tool for families and carers, for disability professionals and health professionals. We need such pathway tools for whole of healthcare too. I'm trying to convince Commonwealth Government to fund such a thing. If anyone knows anyone we need to talk to, just let me know. Our ID Health Education website, this sits largely behind a paywall. There are some free resources. That's all coming over into the Knowledge Exchange Hub for the National Centre and will be free. I'm anticipating that will be early next year. Numerous modules. There's about 55 modules in there for families and carers, disability and health professionals. The NDIS Quality and Safeguards Commission has produced some great evidence summaries which help us understand what the evidence is for the effectiveness of prescribing and cautions us really well. There is a whole national framework for reducing and eliminating restrictive practices in the disability services sector. That's rarely known by healthcare providers. It sits over in the disability sector, but actually it's really relevant for all of us. I encourage you to look at it. There's a new clinical care standard that has been issued by the Australian Commission on Safety and Quality in Healthcare. What is this? It's a standard of clinical care to ensure safe use of psychotropic medicines in people with cognitive disability. We must treat this seriously. This standard holds us all to account. And so if we're not aware of what's in it and what our obligations are, and something goes wrong, this is what we'll be measured against. So I'd encourage you to have a look at this. There are some great tools. There are setting of expectations, how healthcare services and individuals can attain them. There's a wonderful kind of table of contents which helps us think about comprehensively about this issue. And I think it's really important that we engage with it if you can. There's also a new standard user guide for the health of care of people with intellectual disability issued by the Commission. And I'd also encourage you to look at this. Every aspect of our healthcare standards is really regulated by this authority. And what they've done is taken the usual standards applied to everyone and contextualise them to people with intellectual disability. This is great work and really should be looked at. There is also a service standard associated with prescribing and medication reviews in there. So that's worth having a great look at. If you want to learn more about the work of the centre that was mentioned before, the National Centre of Excellence in Intellectual Disability Health, you can email us to sign up. We've got seed grant round that finished this week. I'm looking at the applications now. It's fantastic to see so much excitement and activity in this space. There's events and webinars. There's lots of opportunities. There's PhD scholarships. If you know someone who can enrol either in Melbourne, in Perth, in Sydney for a PhD in this area, let me know. We've got scholarships going and they're underprescribed. There is lots of ways you can get involved, including in our national conference coming up in early July. There should be a QR code, but it's not coming up, unfortunately. Never mind. I think I've gone over time and I look forward to more chats later. Thank you.
Thank you so much, Professor Troller. You can see Professor Troller's depth of knowledge and experience working with people with intellectual disabilities and developmental disabilities. As you were talking about the importance of person-centred strategies and supports within the context of good prescribing and de-prescribing, I saw my aged care colleagues in the audience nodding, because what you were saying absolutely applies to the aged care context. I saw people in the paediatric settings nodding and saying, yes, this applies to children and young people. I saw people from our mental health sectors nodding and seeing the importance of that within these sectors. This is a cross-sectoral issue that is so important for the people in this room and the people beaming in all across Australia. We are making beautiful time today. Thank you so much. Our speakers have been absolutely brilliant. Can you please give them a round of applause? Now, we will take a break for morning tea until 11:15. You'll have a great opportunity to mingle and network with your colleagues. After the morning tea, we'll have 3 concurrent sessions. If you cannot get enough of Dr. Mark Horowitz and Professor Julian Troller, please join me and Michelle Zub in concurrent session 1, where we'll be doing a Q&A panel to really unpack some of the issues that they've talked about earlier today. Connie Wu is here from the Office of the Victorian Senior Practitioner. I'm going to make you stand up, Connie, and say hello to everybody. She will be running our second concurrent session with Phoebe Wallace-Mitrovic and Nicola Hunt in the second concurrent session. And we also have our brilliant team from the South Australian Intellectual Disability Health Service here as well. They'll be running a session with Lisa Henderson and Janelle Fitzpatrick in room 3. So please join us in the concurrent sessions. For the people in the room, your numbers will be at the back of your lanyard if you forgot which session that you signed up for. Please enjoy morning tea, and we'll be back at 11:15.